Three, two, one. We are live now.
Shweta, give me the cue when I need to start.
Sure, sir. So we can start.
Good evening, ladies and gentlemen. Welcome to another interesting episode of Blood, the Life Savior. This is episode number 3rd. And today we have the honor to have the topic, the many phases of immune thrombocytopenia from prestigious institute, Narayan Health, Bangalore. We assure you it's going to be very interesting. This has been achieved because of our course directors, Dr. Biju George and Dr. Joseph John. Both of them in the field of hematology needs no introduction. Dr. Biju George is Professor, Department of Hematology at prestigious CMC Hospital, Vellore. And Professor Dr. Joseph John, sir, is Professor and Head Department of Clinical Hematology at CMC Hospital, Ludhiana. A warm welcome to the excellent team of Narayan Hospital, Dr. Sharad Damodar, HOD, Dr. Akshata Nayak, Dr. Shilpa Prabhu, and Dr. Meghla and Dr. Anusha. As you know that normally this is done over a period of 1.5 hours. So we assure you they will try to wind up by 8:30. Both our program directors have asked to keep their introductions very, very brief. They are extremely humble, but their contribution to the field of hematology is immense. Professor Dr. Biju George sirs is a clinical scientist with more than close to 2 decades of managing hematology disorders. He has been into various preliminary boards and his contributions is immense. Close to 300 plus publications, contributions to book chapters, and has initiated over 200 plus haploidentical transplants at CMC Vellore. Our second program director, Dr. M. Joseph John, sir, is now heading the foothold of hematology in the northern part of India. He is at CMC Hospital, Ludhiana, 30 international and 38 national publications, 7 book chapters, immense contribution to the field of hematology and to bring up the young budding talent and doctors across the country. May I request both our program directors to take it forward and initiate the academic web series from here.
Thank you, Dr. Manoj. Welcome everyone to this webinar. As you've seen over the last 2 webinars that we had, our aim has been to try and put forward topics which are of interest to all of us in the clinical field and which are common. So we had the aplastic anemia as the first one, we had iron deficiency anemia, and now we have immune thrombocytopenia. And what we are trying to do is to use case descriptions to help discuss about various aspects of the disease. I'm sure all of you are familiar with ITP and the challenges we face in managing patients with ITP. Some of the patients, it's very simple, straightforward, but in a number of cases, we run into trouble because they just do not respond or they get other complications. And then we are trying to manage the thrombocytopenia and other problems that occur along with it. So today we have the team from Narayana Hridayalaya, which are going to be talking about the many phases of immune thrombocytopenia. And without wasting too much of time, I will hand it over to them to go ahead and start the discussion. Over to you, Anusha and Meghla. Yeah, Sharad has joined. Joseph,
Hi, good
would you
evening.
like to? Good evening, Sharad. Joseph,
Good
would you
evening.
like to say a few words before they start?
Yeah,
Yeah,
so
so
yeah, Joseph, good.
so Sharad, let me introduce you officially. So Sharad was few years senior to me when we did DM in CMC Velo. It's a good senior to us. Right now, he is heading the Narayana Hridayalaya Hematology Department, and he has a training program, DNB fellowship programs at the center. And over to you, Sharad, for an overview and introducing your team.
Yeah, thank you, Biju, and thank you, Joseph. It's like a nice little mini CMC get together, so it's nice, right? So so clearly, we thought ITP will be a topic which will be of interest to the PGs, and that was the intent of having that topic. And I can see about 150 people already have logged in, which is very nice. So what we thought is we have two cases which I think the PGs will present. Just to give a little flavor of ITP, Dr. Shilpa, who I'd request to just have a little discussion, and we can address some questions to both Dr. Biju and Dr. Joseph also on that, just to have a little thought on those cases. And then at the end, we'll have Meghala also present the current ITP guidelines and its kind of relevance to India. I mean, the ASH guidelines of what currently existing, so that it's of use to the postgraduate. So that's the overall plan for the program. So if we can start with the PGs with the first case, you all present your first case, and then we'll kind of discuss and then move on to the second one. I think just go on to the cases. Yeah, we can.
Good evening, everyone. The first case, a 39-year-old male known case of IBD ulcerative colitis, psoriatic arthritis, which was diagnosed in December 21, and he was off treatment since 23. He presented to an outside hospital with symptoms of cramps in the abdomen, frequent passing of stools, blood in stools, and history of weight loss of 3 kg in the past 1 month, for which he was planned for a colonoscopy. No history of fever or any bleeding manifestation, and routine evaluation for colonoscopy at Fortis Hospital showed his CBC on 13 December 24. HP was 16.2, platelet was 42,000, and total count was 10,600. Dengue IgM was positive, dengue IgG was positive. So they were managing it as like dengue fever, and repeat CBC done on 20th of December showed an improvement in platelet count to platelet of 1,20,000. And they had repeated one more CBC on 23rd December, which showed a platelet of 1,50,000. The colonoscopy was meantime deferred during this period in view of suspected dengue fever, and his platelet was monitored. Repeat platelet on 26th of December had dropped to 30,000. So he was referred to our hospital for further management. And his background history is a known case of IBD ulcerative colitis, which was diagnosed in December 21. And initially he was on mesalamine and sulfasalazine for 2 years, which was later stopped in 23 as his disease was in remission. He was also diagnosed at this time with psoriatic arthritis concurrently, for which he was on symptomatic management, that is like analgesics for the pain. When he came to our hospital, general examination was not remarkable, like pallor actress was absent, no lymph nodes were palpable, his vitals was normal, and systemic examination was normal with no organomegaly. And evaluation at our hospital, the CBC done on 1st of January 2025 showed HP of 16 and counts 9.3 and platelet 20,000. His ANA profile was negative and vitamin B12 levels were 592. We did the bone marrow aspiration. This is the low power view of the bone marrow aspirate showing megakaryocytic hyperplasia, and this is the high power view showing the normal megakaryocytic hyperplasia. So the bone marrow report was suggestive of like consistent with ITP with megakaryocytic hyperplasia. So he was admitted with the above complaints. So we started him on methylprednisolone 125 mg once daily for 3 days, and he also received 0.4 gram per kg of IVIG. Later, he was switched to oral steroid, that is prednisolone 1 mg per kg when he was discharged. And at follow-up, his platelet was 12 lakh on 11th of Jan 25, which was after 1 week. And he was also facing multiple adverse effects with steroids like lack of sleep, acneiform eruptions. Hence, his steroids were rapidly tapered and his steroid dose was reduced to prednisolone 10 mg OD. And he came after 20 days with on 28th of Jan 25 with a drop in platelet count to 10,000. Hence, his steroid that time steroid dose was increased to prednisolone 40 mg OD from 10 mg OD, and he was also given one dose of romiplastin 250 mcg and methylpred 125 mg was given. Meanwhile, he was also started on steroid sparing agent MMF 500 mg BD from 28th of Jan 25, and over the next few days, prednisolone was slowly tapered to 30 mg OD. But after starting MMF, he started having low-grade fever spikes, which was persistent for about 2 weeks. So MMF was stopped on 11th of February 25, and he was started on azathioprine 50 mg OD from 17th Feb 25 after discussing with the gastroenterologist, since he was also having features of ulcerative colitis. So azathioprine would help in both ITP and ulcerative colitis. And his steroid dose was further tapered to prednisolone 20 mg OD. And after this, his platelet count started improving, and it improved to 19,000 on 24th of February 25. Once his platelet count stabilized, he underwent colonoscopy on 26th February 25 for evaluation of ulcerative colitis. And the colonoscopy showed flare-up of ulcerative colitis, so he was restarted on treatment for the same. And meanwhile, the tissue for CMB was also positive, but concurrently blood CMB was negative. He was started on, for the treatment of CMB, he was started on valganciclovir 900 mg. This is his biopsy report, which was the biopsy was sent to CMC. There it showed features of ulcerative colitis, and also the CMB infection was positive in the biopsy. So at the latest follow-up, his steroids has been tapered to prednisolone 10 mg OD, and he has been quite well tolerating the azathioprine, and his dose has been increased from 50 mg to 75 mg OD. And his latest CPC, which was done last week, shows HbO 14.6, counts 10.2, and platelet 150. Plan is to further taper and stop his steroids, and he is also currently continuing valganciclovir 900 mg for the tissue CMB infection, which was detected on the biopsy.
Yeah. So thanks, Anusha. So Shilpa, you want to discuss this, or shall I?
Sir, Akshita would be discussing.
Akshita wants to do this. Okay.
Sir, I would like to discuss this case.
Yeah. Please go ahead.
So, the questions to the three seniors here. So, this patient is a case of ulcerative colitis, and he was in remission when this thrombocytopenia started. And there's a preceding dengue fever here. So, what is the incidence of ITP in dengue patients, if I may know from your experiences? Biju sir, to begin with.
I mean, I don't know about ITP and dengue, but what we generally see is a patient who presents with dengue, thrombocytopenia occurs, then the dengue actually resolves, the fever, everything resolves, but the thrombocytopenia either persists or there is a resolution and then within a month sort of drops again. That is the common scenario that we see. Initially, you're not sure whether the thrombocytopenia is related to the dengue infection or whether it is concomitant ITP, but as you sort of keep following up the patient and you know that the dengue has completely resolved, all the other parameters have improved, but it's only the platelet count alone which is there, which is low, then you sort of assume and presume that it is probably related to immune thrombocytopenia, and so treat it as such. That is probably the scenario what we commonly see.
Yeah, Dr. Akshita. So before we get into the whys and hows, I wanted to understand the final diagnosis of this patient according to you. Underlying ulcerative colitis while in remission. I missed the age of this patient. Can you just tell me the age?
40 years.
Can you go to the first few slides? Because I want to get the problem statement very clear before we move ahead. So basically, what is the age of this patient you said?
40 years.
Sorry?
40 years. 40.
40-year-old lady for ulcerative colitis for how many years?
For the past 2 years.
Huh?
From 2022, sir.
Can't hear you, so I'm really sorry.
2022, from 2022.
Okay, so now it's a 3-year history of ulcerative colitis in remission. And what was the medication she was on while she developed this? She was on Mesacol or anything else before this?
No, sir. Since past 1 year, not on any medication, sir. Since disease was in
Not on
remission,
any.
not on any.
Okay, do we have an ANA on her?
ANA is negative, sir. ANA profile we are
Okay. So we have an ANA negative underlying ulcerative colitis. Now the question is it not secondary ITP? Then we'll are saying is a primary ITP only. And the entire course is spanning for 1 month, if I understood, 2 months, if I understood correctly.
Yes,
So when you started on IVIG, the platelet went on to 12 lakhs within 3 or 4 days. And then it is finding a steep drop within 4 weeks. And then you started her on MMF. And what made you switch from MMF to azathioprine?
because he was having fever spikes for the past 2 weeks, which we were not able to explain what was the cause for his fever spikes after we started him on MMM.
So little background here, Joseph, I will cut in,
Yeah.
so this is a little bit of the, high flying Google patient with some doctor relatives. Okay. So I will put you, and it's a he, not a she. Okay. So I must state
I'm
that
so sorry.
background. Okay. Because even the guidelines say you look at patient care and patient well-being and all of that, So he himself decided. So this is somebody who's been ping-ponging between hematology and gastroenterology between two
Okay,
different
fine.
hospitals. Okay.
Ah.
So that's the first thing. And the gist of it was the gastro wanted to do a colonoscopy. And because of the platelet, they kept deferring it, saying that I want a 1 lakh platelet count before I go
Correct.
and scope. So that was the
Okay,
gist of it.
fair enough. Fair enough.
Now, dengue recovered and they thought they were going, but the day they did the count, the platelet was 30,000 or something. So they said, we won't scope, we'll send you across. Okay. Now he's come in panic saying that, I want whatever treatment. So, give me urgently, blah, 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 all of this. So IVIG and steroids went in, marrow done. Okay. With that, he improved very well, but started developing horrendous side effects with steroids and kept cribbing about the steroid and wanting to cut it down himself and take it off. But the platelet jumped up in the meantime, and then we did try and do a fast taper of steroids with an intent that we'll kind of bring down steroid and send him for the scopy. But what happened was the platelet crashed after that 12 lakh jump, and then had to put back, and thereby he got a shot of Romy also at that point in time, trying to basically get the scopy done because that was his primary aim. Get my platelet to a lakh for me to go for a scopy, because this was somebody who was not on any medication for the UC, and that was also troubling him in the meantime. He was having persistent diarrhea, abdominal pain, some flatulence and all that, so that was also kind of at the back of his mind. So again, after a chat with gastro, they also told him, why don't you speak to hematology and see when they're doing a steroid taper, can we add MMF? And that was added, thinking that it will kind of help both sides. But he had a persistent fever for which we didn't have an explanation, which he attributed to the MMF and discontinued. Okay. I'll tell you that. So that's a background. Okay. So he decided that ever since I started the MMF, I've been having this problem and I want to take a break
We lost you there. Viju,
Okay.
Anusha, you're
So he
there, right?
stops it and then come look at as
No,
a
no,
rat.
one sec.
Instead of
Sharad,
you
we
overlap the
lost
both,
you
during
when
which
he
time he
took a
got them
break.
to actually
Sorry,
do whatever was going on.
sorry.
You know,
Sharad, we lost you when he took a break.
I didn't take a break. Okay. So anyway, I'm coming back. Okay. So when he took a break from the fever, from the MMF, the fever settled
Ah,
down for his luck. Okay.
ah,
And
ah.
by which time he was good enough to get the colonoscopy and got it done. Basically because gastro wanted that done. And the surprise on the colonoscopy was that came back as CMV infection. Okay. And
Hmm.
so immediately wanted to start valganciclovir. Again, the issue of that producing further thrombocytopenia, and then so keeping some more drugs to keep that at a level which was good enough for him to maintain and take the full dose of valganciclovir. Okay. So that was the sequence of events.
Ah,
Uh, so things which we thought we can discuss from this is one is what already Akshita asked Dr. Biju about, how many times we are seeing ITP or slash immune thrombocytopenia post a dengue episode. And the second one was CMV by itself. Can it present as, thrombocytopenia, or can it be a trigger? Do these go to in hand in hand? And is there this background IBD, which is possibly, again, an immune mediated problem, and then he's manifesting that down the line, and whether some immunosuppression provoked him to get CMV in the first place. So these are 2, 3 things which we thought we should bring up for discussion, because this is not something we routinely chase.
sure. Thank you, Sharad, for that discussion, because it came, I mean, being frank and discussing that, because that's a real life scenario. And I think the students who are listening to this discussion will understand the ground realities of how we manage. Everything is not textbook style always. So that was very good. In fact, you have taken up this case. So, my take on this would be, one is to say we are asking the question, why is there immune thrombocytopenia post your dengue, and dengue got settled, and after how many weeks of dengue fever defervescence did he have the drop in platelets?
I think it's about a month, Anusha, on your first 2 slides. It's about a month, I think, month and a half.
Correct. Now we are asking the question, is dengue the culprit of thrombocytopenia directly, or is it post-viral dengue or anything which is caused in immune thrombocytopenia by molecular mimicry, or is it CMV? These are the three burning questions here, right? In terms of
Correct.
the question why. So first one, I would say, because it is 1 month from the defervescence of fever, that is unlikely a direct suppression by the dengue. I mean, even though it's an endothelial activation and all those, the etiologies are there. Post-viral, any viral molecular mimicry, high possibility. If it is CMV directly causing, what was the CMV? Do we have a PCR of, or is it an inclusion body you saw?
Inclusion body on the biopsy, the blood CMV PCR was negative.
Okay. So the question now is, if the blood is negative, only gut involved, can that directly cause? Even if it causes, it may be an immune phenomenon is the cause. So to me, it looks like a molecular mimicry forced viral, which would have triggered off. But answering the question whether it is dengue or CMV is not going to solve the problem for us.
Right. So
That I'll stop there. Yeah.
So CME association, I think maybe we'll get Biju's thoughts also on this, because this is a total, surprise for us on, kind of presenting as like an immune thrombocytopenia with the background of CMV sitting somewhere else.
So, Sharad, I mean, I would say there are I would put it as two different disease processes going on in the patient. Now, why should a patient like this develop CMV?
Right.
I would think this a background of ulcerative colitis with treatment with sulfasalazine and steroids is probably the reason why this patient has got CMV in the gut and not CMV viremia. Now, can CMV cause thrombocytopenia? Yes, it can cause thrombocytopenia, but that is usually a cytopathic effect or an immune-mediated damage commonly occurring when you have CMV viremia,
Right.
not when it's isolated CMV in the gut, it is very unusual. So I would think that the CMV infection is more likely to be related to the underlying inflammatory bowel disease and the treatment for that. And you've got a thrombocytopenia, probably immune thrombocytopenia, probably precipitated by a viral infection, where here it is dengue.
Right. Yeah, Joseph, anything else from your side? Anything different there?
No, from an etiological basis, I mean, all of this are conjunctural only, we can say. We cannot prove it in any manner. Whatever the assumptions we make here. Having said that, does this answering that question help us in managing the patient? I am not too sure about it. We have to anyway treat the CMV, and that may have a consequence on the ITP as well. No, I mean, I'm also, just raising these questions. I'm thinking loud essentially.
Yeah, fair enough. Yeah, agreed. It was a concern when he was on Valgan, thinking that, that's going to now hit the platelet count again. So what will happen to the amount of, medication we'll have to give? But thankfully, he settled down on a small dose of steroid and Azoran, and he was on the steroid taper. Now, again, the fear for us, typically when you're on immunosuppression is, will that flare up the CMV infection when you're adding stuff like, Azoran and MMF? So it is double-edged on Valgan. Now, how will you monitor this patient? As of now, the only evidence is on the colonic biopsy tissue, to really check for disease, because we don't have any other indicator for the CMV status. So that gastro will then take a call on whether they want to re-scope him again and biopsy again, to then look for clearance of that.
So Sharad, I would
Yeah.
say, if taking on from how we treat CMV colitis in patients who undergo allogenic transplant, we definitely would repeat a scopy after 3 or 4 weeks, repeat biopsies to see if those inclusion bodies have disappeared. That
Right.
is the only way you would be able to be reasonably sure that the CMV sort of come under control with that medication.
Right, right.
What is the duration of treatment that Dr. Biju you suggested?
So if you look at, because this is CMV in the gut, which means it's CMV disease, you're looking at least at 4 weeks of therapy, followed by at least 4 weeks of maintenance. This is not viremia, the CMV disease.
Right, right. Yeah. So, Akshat, any other questions from your side?
Yeah, I had one more doubt. This is just a theoretical question. Was it a flare of ulcerative colitis with an extraintestinal ITP, where we should have started steroids and azathioprine from the beginning itself?
Yeah, so with the ANA coming negative, we don't have any other evidence for other systemic, even though the mechanism can still be there. He actually got steroids anyway, I think, as his upfront treatment. And it was a toss-up between adding MMF and Azoran as the steroid sparing agent. I mean, we'll come to that point a little later on what can be the second-line therapies. But I think that was the thought, that initially the two were kind of delinked till we got this biopsy coming in, with this other diagnosis of CMV. Because you had somebody in remission and just started manifesting some symptoms. And then when he was getting prepped, just on the day of the colonoscopy is when you had a drop in platelet count. Now, it's really difficult to prove whether it was running parallel. The only other thought which I can thinking is there any worthwhile to look at platelet antibodies here? I'm keeping that question open.
I mean, I would say hardly any labs do a platelet antibodies. And if you do also, you're just going to say, is it IgM, IgG? I don't think it's going to help you in any way in terms of, if you're looking at what the etiology is, I don't think you'll be able to sort it out that way.
Right. Yeah, because some people believe in trying to look at, platelet antibodies when they're working up as part of the thrombocytopenia. That's why I just raised that point.
Right now, there is no evidence, no,
Correct.
Sharad?
Yeah. Nobody recommends doing it.
Yeah.
Fair. Akshata,
So
any other
you,
questions from you?
Such a set of
so
patients before
go
starting
ahead, Akshay.
steroids.
Go ahead.
Should we routinely test for CMV before starting steroids in such set of patients?
Whoa. Okay. I mean, I think guidelines will come to that, but I think we can take thoughts from Biju. Is anybody doing it at all?
No, I don't think that is
No.
why I mean, I would say at least we have treated more than at least 5,000 patients with ITP at CMC over the past 15, 20 years. I've never seen CMV occurring. So that is why I think that is more, and it is not even viremia. It is
Correct.
CMV disease. That is why I think that is more related to the inflammatory bowel disease than it being due to steroids being given for the immune thrombocytopenia. And if you look, people, there is a big list of viruses you should look for if you are seeing a patient with ITP, including CMV is mentioned in that, but practically we never do it.
And Akshata, even if you've done it here, the blood CMV was negative. So, like Biju mentioned, and we'll come to those slides. I think Meghla will present on what is the causes for secondary ITP. We can actually show it just as a teaching thing. Yeah, before we close this case, one another provoking thing is combination of IVIG and steroid. I mean, when you're not giving it at the 1 gram per kg dose. So, are you all doing that, Biju, okay, on occasions, and Joseph after that?
Yeah, I think we do it.
Yes.
So if we were giving straight up upfront, I would give the IVIG, wait and see whether there is a response or not before adding on the steroids. But many times what happens is you give the IVIG, you get that temporary rise in platelet count, but down a period of time, you would see it falling down. And so you try and add on the steroids to keep that platelet count up and going. It's
Right.
similar what we do even when we give high dose DEXA for those who cannot afford IVIG. You give 4 days of high dose DEXA and then you follow it up with oral steroids. That is what we
Right.
practice.
Right. Right. Joseph, your
So
thoughts?
Sharad, yeah. So basically, the reason why I give IVIG is only if, like, your patient is very apprehensive, they don't
Right.
want to take the risk of even 1% risk of
Mm.
an ICU bleed. I don't mind spending 1.52 lakhs. Those are the only reason when we give IVIG. So almost always I overlap with the steroids. Now I don't know whether there is any study to say that steroids should not be given along with IVIG. But like what Dr. Biju said, IVIG we are only as a temporary bridging, and steroid is the mainstay in terms of knocking off that clone which is producing the antiplatelet antibody. So it's logical to give both. If you are done a marrow and you want to go ahead. Now, it's a child, I don't want steroids, I don't want marrow, then IVIG alone.
Fair. Absolutely. Okay. So I think that's a good teaching point. And clearly, practice is different from the book. I think that's what is being highlighted here. And we will also try and highlight that in the subsequent case. So that was the idea of having these cases so that we have good discussion. So can we move on to the second case? Because we are already, I think,
So
half an hour into it.
before that,
Yeah.
Sharad, since we are on this
Oh.
enigmatic case here,
Mhm.
what is the definition of steroid refractory ITP? And this is a newly diagnosed ITP, right? This is not secondary, this is primary. It's important to document this as primary ITP, ANA negative. You may have thought it is secondary ITP because of ulcerative colitis, but it is not. I don't know whether we will label still as secondary ITP. Otherwise, it is a newly diagnosed ITP, less than 3 months from the
Correct.
diagnosis, right?
Correct. Correct.
And any definitions on steroid refractoriness before we start the second agent?
Yeah, so that will come up in the guideline which Meghla will put up, the
Okay,
ASH
we are going to do
guideline.
that. Good,
Yeah,
good,
I
good,
think
good.
we'll bring it
Yes.
up there,
Okay.
so that we
Okay.
know what is defined and then what we do will come after that.
Okay. Sure. Sure.
Right, second case.
Moving to the second case. Background history, she is a 39-year-old lady, P2L1A1, no comorbidities. She's a known case of ITP diagnosed in 2004 when she had presented with gum bleeding, and initial investigation CBC had showed HB11, total counts 4.5, and platelet was 20,000. ANA profile was negative and bone marrow was consistent with ITP. She was initially started on Vislon 1 mg per kg. Later it was tapered over the course of follow-up to 10 mg once a day, and later it was made alternate day 10 mg. And for some time she was in remission. Then in between she had a drop in platelet. Then that time she had received 2 doses of IVIG, which was in 2008, and she was well till 2017 on regular follow-up and maintaining a platelet count of 60,000 to 80,000, and was on Vislon 10 mg intermittently till 2017. Later in 2019, she presented again with gum bleeding and was found to have platelet count of 15,000. Repeat ANA profile, serology, everything was negative. Thus, in view of the relapse, she was given rituximab 500 mg once a week for 4 weeks, following which she was in remission till 23. And in Jan 23, she again presented with thrombocytopenia, for which again second course of rituximab was repeated weekly once for 4 weeks. And last dose she had received was on February 23, and she was also meantime started on L-thrombopag 15 mg OD. Once her platelet count stabilized, later tablet L-thrombopag was changed to 50 mg once a week from March of 23, and later it was changed to 20 mg once a week since July 23. And when she presented this time, her platelets were almost stable at around 80,000 since the 23. And on 16 Jan 25, she presented to us with complaints of paresthesia of right hand, index finger, and middle finger since the past 3 months, and also gives history of current shock-like cramps on the left forearm since past 1 month on and off. She also had history of bilateral hand joint stiffness, burning sensation since the past 3 months, and she also started noticing some erythematous hyperpigmented papules plaques on the face, ear since the past 4 months. And no history of any joint pains or joint swelling, no Zika symptoms, no history of any Raynaud's. She gives history of intentional weight loss of 10 kg in the past 7 months. This is her picture when she presented to us in Jan 25. She had presented with multiple lesions on the cheeks and on the ears and even on the nose, multiple erythematous plaques. And this is the picture of her during the same time when she presented with the multiple erythematous lesions since Jan 25. Family history, nothing more significant, only diabetes mellitus in the father. Obstetric history, she has one bleeding child, and use history of one MTP, which was done at 4 months of gestation, 14 years ago. At 20 weeks she had done. And her examination pallor request was absent. She was having multiple cervical lymph nodes, bilateral level 2, 3, 4, and largest was around 2 into 2 centimeter. And cutaneous, her skin was showing erythematous hyperpigmented papules, plaques on the face, ear, retroauricular area, and few on the scalps. And her vitals were normal. And systemic examination was unremarkable, with all systems were normal. And the investigations after that, when we had done in Jan 25, were showing CBC HB of 13.6, platelet was 150, counts were 4.9, renal functions and liver functions were normal, serology was negative, and immunoglobulin levels were normal, spot urine creatinine ratio was normal, and USG neck was done because of the enlarged lymph nodes, which showed multiple bilateral level 1, 2, 3, 5 lymph nodes, which was the largest was 2.5 into 1 centimeter, with the partial loss of fatty hilum. And her ANA profile was 3+, immunofluorescence was 3+, with profile showing nucleosome 3+, ribosomal protein 1+, SSA RO borderline, RNP SM borderline, AMA M2 positive, dsDNA borderline, and histone was borderline, with dsDNA of 717, which was positive, and C3 was low with 57, and C4 was less than 8. She also underwent an ABLA workup, which was negative. Then she underwent a left cervical lymph node biopsy, and the features were favoring the reactive lymph node enlargement. So she was referred to the rheumatologist, where she was admitted, and she was diagnosed with SLE. So she received injection rituximab 500 mg on February 13. And she was meanwhile also started on MMF 360 mg 202, and she was also started on prednisone 10 mg OD with HCQ 300 mg OD. Since her SLE was active and there was also risk for thrombosis, hence her L-thrombopag was stopped. And her latest follow-up CBC on 17th March, HB is 13.6, platelet 125, counts are 4.9. And at the latest follow-up, there is an improvement in her skin lesions when she has responded well with no any systemic other organ involvement.
Yeah, thanks, Anusha. So, Dr. Shilpa, will you discuss or ask questions on this?
Yeah, sir. Thank you, sir. Sir, actually, if you look at this case, initially it was a primary ITP because ANA being negative serology and almost all the secondary causes of ITPs were negative. So she had a relapse at that time. Again, we had repeated the ANA and the serology, which was negative. Subsequently, it has evolved into a secondary ITP, which is secondary to SLE. So my question here is, do we repeat the ITP workup to look for secondary causes at relapse? And if so, how frequently do you do it in patients like this who have frequent relapses and remissions? This is my question to Biju sir and Joseph.
No, we generally would not. So we need to remember is when we look at collagen vascular disease and ITP, it can precede, it can come along with the ITP, or it can manifest many years after ITP. Now, the only thing in terms of treatment which you may consider doing less if it was secondary ITP as compared to primary ITP would be the question about whether you would actually do a splenectomy, because there's clear data to show that if it's a secondary ITP, the outcomes of the splenectomy are not as good as if it was a primary ITP. So we generally would not, even in a relapsing patient, we would not repeat the collagen markers unless there are any clinical manifestations where we suspect that there is a flare-up. Because remember, if you ask the rheumatologist, at least our rheumatologists say, even if you get an ANA positive, that alone is not enough to fulfill criteria for treatment unless the specific criteria for diagnosis is fulfilled. So unless there are clinical manifestations, we generally would not keep repeating the markers. Joseph?
Yeah, so the way I look at it is a 39-year-old lady spanning the disease over almost 17 years, if I look at it correctly, from 2008 onwards with multiple relapses of ITP. And ANA repeatedly has been done, and that is negative. And then you are on the right track. You're not clinically seeing any secondary causes or any manifestations of a mixed connective tissue disorder or a collagen vascular disease or SLE there. And therefore, you're justified in not evaluating extensively except for an ANA, because ANA becomes mandatory to look at SLE. Now, after about, if I look at the history correctly, if I got it right, after about 15 or 17 years later, or 16 years later, she is manifesting with the skin manifestations, and ANA now becomes 3 positive, 3 plus an anti-Rho and something else and all are positive there to look at rheumatological manifestation by skin and node. When you rightfully looked at the lymph node biopsy, there is no tuberculosis or a lymphoma there to find out. DCT I could not find, but HB was normal and therefore I assume that is negative. The only result I could not find there was a urine 24-hour urinary protein or a urine routine to see if there is a kidney involvement for SLE. Now, she may have fulfilled all the criteria for SLE, and by default, you've been giving rituximab prior to that, and probably that masked the early manifestation of SLE, probably, I would say. And then there's a breakthrough which has happened, and she's now come with this. And you're essentially treating with the same disease, same treatment. APLA is negative, and rightfully, you have avoided romiplastin because of the thrombosis, and now with immunosuppression itself you are getting the thing. So your question, I mean, I've long answer to your short question was, do you want to do extensive evaluation of collagen vascular disease? The answer is no, unless you have some findings, but you would definitely ask those questions: oral ulcers, joint pains, hair loss, all of that you would ask for sure.
Yeah, just to add to that, Shilpa, the urine PCR was done, I think, which was normal there. There was no 24-hour urine protein there on completion. And one Coombs in the past was negative. This is a patient who's also had other drugs for immunosuppression before she went on to Ritux. And I think that's a very valid point which Joseph also brought out, that when we are doing this Ritux, can we kind of sometimes mask a potential, flare up or, unmasking of SLE, because she's actually got 2 rounds of Ritux and the second time didn't respond so well to Ritux, and thereby, by which time, Eltrombopag became available in India, and that's how she went on to that. Till then, she was being managed with other things. That's the reason for the 2 rounds of Ritux. So, question to both Dr. Biju and Dr. Joseph is, one is, do you all do multiple rounds of Ritux, and if so, at what interval? Yeah, so that's a primary thing. And also, this business of L-Trombopag or its derivatives, which are now available at frequencies which are, occasionally once a week, twice a week kind of thing. So, 2 questions to both of you all.
So
Biju first.
I would consider a second round of Ritux if the patient has had a reasonable response with the first round and is shown response with the platelet counts going above 100,000, but subsequently has a relapse. Yes, I may consider it again. Generally, if you do respond to either romiplastin or eltrombopag, I don't think there are very clear guidelines for how long you treat and how long it goes on. So I generally would give the full dose for at least 6 months, and then provided the platelets are below 4 lakhs. So between 1 to 4, I would like to keep it at the same dose and then slowly reduce it and try and stop it. Now, is that based upon guidelines? No, but it's based upon our previous experience with multiple drugs, that if you sort of stop them quickly, the chances of relapse are much higher. So we would go down from, if you were on 50 to 25 daily, then come down to 25, 5 days a week, 3 days a week, and then try and stop it.
Right.
So,
yeah.
Sharad, so at this point, generally the thought process is, I want to know the organ involvement of SLE. Is it lung? Is it kidney? Is it any thrombosis? So that will essentially guide the next course of choice of therapy, because now we have to choose between MMF, rituximab, cyclosporin. If the kidney is okay, then cyclosporin, I mean, this is of course in discussion with the rheumatologist, and generally this is the thinking process, thinking guidelines, or thinking boxes we would put in. I want to use cyclosporin. So our aim is to give the least dose of steroids and then switch it with a T-cell immunosuppression. There is what we need to do. So we have choice of MMF, Ritux, cyclosporin, and of course many other agents we can consider. If lung was involved, generally our rheumatologist was leaning towards MMF. If kidney was more involved, rituximab, and then rituximab maintenance once in 6 months after the initial course of 4 weeks. If there is thrombosis with thrombocytopenia, then the plot thickens a little more. And then we have to choose between the devil and the deep sea there and make your call on whether to use romiplastin or eltrombopag there. So, long story short, I would look at the organs involved and choose the most suitable organ or agent, along with keeping the base of hydroxychloroquine there, and doing the ophthalmology checkup, etc., and then giving the lowest possible steroid with either MMF and or Ritux, depending upon the agent, or cyclosporin. Affordability also will come in play here.
Okay, now back to that original question which I asked Biju, Joseph. Have you done 2 rounds of Ritux, and if so, at what gap and on what basis? And if you used L-Trombopag, how long before you decide to taper, and what's the lowest dose you would leave people on?
I don't think, Sharad, we can give a clear-cut answer. Now, if I were to give Ritux very often, I am little worried, and I have done it, but it is not basically mandated CD20 levels to see if there is any CD20 left at all. Though that may not be as come of the criteria, but you can thumb rule, you can say if you are giving a rituximab going on and on, generally I would leave it at 6 monthly gaps, if at all. As a recovery time. Yeah.
And the L-Trombopag taper?
Eltronopag taper will be based upon leaving a minimum, leaving target platelet count of 30,000, whatever the least which you can put, I would taper and stop. That would be my priority, to take off the TPO agonist as early as possible.
Okay. Questions from Shilpa, if you have any? Shilpa?
Sir, do we use a combination of romiplostim with L-Trombopag? Not in this case, in general, in cases of refractory ITP, when single agent romiplostim doesn't work or L-Trombopag doesn't work, have you seen whether any combination works?
Yeah, we'll ask that to Biju first and then Joseph.
I've
Combinations.
never
Biju.
used it. My worry would be hepatotoxicity when both are being used. So I would combine it with other drugs, but not a combination of romiplostim with.
Right. Joseph?
No, I wouldn't use it. It's like using amoxicillin and ampicillin at the same time.
Right. Okay. Yeah. So generally avoided, but combination with other drugs is a possibility. Yeah. Any more questions, Shilpa?
No, sir, I think you have covered most of it.
Okay. So if Meghla, you can just present the guidelines, first, and then we'll do some discussion post that on, second line drugs and what is, our role of splenectomy and things like that.
So, good evening all. So, I'll be presenting on guidelines on management of ITP. So, a quick overview on ITP. So, as we all know, it is an acquired autoimmune bleeding disorder with an incidence of 2 to 10 per 1 lakh per year. So, coming to the pathophysiology, it is an antibody-mediated peripheral destruction of platelets and also impaired platelet production. So, whenever we get a case of thrombocytopenia, since ITP is a diagnosis of exclusion, we should rule out all the secondary causes like pseudothrombocytopenia, acute or chronic infections, which includes HBV, HCV, HIV, EBV, CMV, like H. pylori, Zika virus, and what we have to rule out, and drug-induced vaccine-associated thrombocytopenia, connective tissue disorders, lymphoproliferative disorders, immunodeficiency syndrome, Evans syndrome, and bone marrow malignancies, and other inherited congenital disorders should be always kept in mind. And depending upon the clinical characteristics, we should rule out the secondary causes of ITP. So, like coming to the pathophysiology of ITP, so what happens is that whenever the platelet autoantigens are there, they are presented by the dendritic cells to the CD4 T cells, which stimulates the B cells to produce platelet autoantibodies. These autoantibodies are recognized by the macrophages and they are cleared by the splenic macrophages. These platelet autoantibodies are clearing the apart from clearing the platelets, they also cause deacylation. The deacylated platelets are recognized by astral moral receptors of the hepatocytes and clear the platelets. So apart from this platelet destruction, the cytotoxic T cells and also the autoantibodies will inhibit the megakaryocyte maturation and causes apoptosis of the megakaryocytes. So generally the ITP is both platelet destruction and impaired platelet production. So the drugs on ITP mainly targets the TPO receptor agonists stimulate the megakaryocytes to produce the platelets, and also like steroids, IVIG, splenectomy, all focus on the B cells by decreasing the clearance of platelets. So coming to the guidelines, there are two guidelines, that is International Working Group and ASH guidelines, which both updated their guidelines for the management of ITP in 2019. So they propose a set of principles for optimizing the management of ITP. So the primary goal of ITP is the following. So first and foremost is to individualize to the patient and on the phase of disease. And it should also prevent the severe bleeding episodes. And the primary target should be maintain platelet count more than 20 to 30,000, at least for symptomatic patients. And the treatment should be within minimal toxicity, and also you should concentrate on the health-related quality of life. So this is a paper from India, where the IVISH study, where they have where they have studied about the patients and physician specimens regarding the ITP as a disease. So in this, the conclusion is that there is a substantial discrepancy in patient and physician perception regarding ITP associated symptoms and treatment goals in India. So always there should be a shared decision making regarding the treatment of ITP between the patient and the physician. So coming to the ASH 2019 guidelines, so there are 21 recommendations which covers the management of ITP in adults and children with newly diagnosed, persistent and chronic disease refractory to first-line therapy. So here the management approach discussed with the observation, corticosteroids, IV immunoglobulin, anti-immunoglobulin, rituximab, splenectomy, and TPO receptor agonist. So before going to the proper guideline, I would like to highlight a few definitions, which is first is the steroid dependent. It means that there is a patients where there is an ongoing need for continuous prednisolone irrigation more than 5 milligram per day, or a frequent course of corticosteroids to maintain a platelet count of more than 30,000. The durable response means the platelet count more than 30,000 and at least doubling of the baseline count at 6 months. The newly diagnosed ITP means the duration of ITP less than 3 months. Persistent means it is 3 to 12 months, and chronic ITP in the sense it is more than 12 months. So by definition, remission is platelet count more than 1 lakh at the end of 12 months. So coming to the recommendations. So first recommendation on admission is in adults with newly diagnosed ITP and a platelet count of less than 20,000 who are asymptomatic or minor mucocutaneous bleeding, the panel suggests admission to the hospital. So second one is in the established case of ITP and if the platelet count is less than 20,000, the panel suggests outpatient management with the condition that the patient should follow up with the physician within the next 42 to 78 hours. In adults with platelet count more than 20,000 who are asymptomatic or only have minor bleeding, the panel suggests outpatient management. Coming to the treatment recommendation, in adults with newly diagnosed ITP and platelet count of more than 30,000, the panel recommends against corticosteroids rather than observation, with few exceptions where the additional patients with additional comorbidities such as who have predisposition to bleeding, anticoagulant or antiplatelet medications, or who are with upcoming procedures, and for elderly patients more than 60 years old, the treatment with corticosteroids may be appropriate. So next one is the patients with newly diagnosed ITP and platelet count of less than 30,000 who are asymptomatic or minor mucocutaneous bleeding, panel suggests corticosteroids rather than just observation. So regarding the choice of steroid, the panel suggests either prednisone ranging like 0.5 to 2 mg per kg per day, or dexamethasone 40 mg per day for 4 days for initial therapy. So there is multiple trials which didn't find any difference in the response rate between the prednisone or dexamethasone. If the physician feels that the rapidity of platelet count is very important, then they can choose dexamethasone over prednisolone. So this is a paper highlighting like high dose dexamethasone is compared with prednisone for previously untreated primary ITP. It is a meta-analysis where they found no difference in overall platelet response at 6 months. But at 14 days, the overall platelet count response were higher with dexamethasone, that is 79% versus 59%. So this is the recent 2024 paper, blood advances, where we can see. So at the end of 6 weeks, the response rate that arm A, which is the prednisolone group, has 78% response rate, whereas in arm B it is 93%. The final response at the 6 months, the arm A, which is the prednisolone group, have 60% response rate, and arm B, which is the dexamethasone group, have similar response rate. So coming to the next recommendation, in a newly diagnosed ITP, the panel recommends against a prolonged course of prednisone rather than a short course. So always we have to taper there should be a rapid taper of steroids, since we know that steroids have many adverse events with a long course of steroids such as hypertension, hyperglycemia, sleep and mood disturbances, gastric irritation, glaucoma, and osteoporosis. And also in the newly diagnosed ITP, the panel suggests against rituximab and corticosteroids rather than corticosteroids alone for initial therapy. So coming to the management of adults who are corticosteroid dependent or unresponsive. So the second line treatment should be always individualized based. There should be patient education, also shared decision making are encouraged in the second line of therapy. So in adults with ITP more than 3 months, who are corticosteroid dependent or unresponsive, that you can start with TPO receptor agonist. The panel suggests either eltrombopag or romiplostim. So here is a table which assess the duration of ITP. If it is 3 to 12 months, the primary treatment option will be rituximab and TPO receptor agonist. So the splenectomy is avoided in less than 1 year. And if it is more than 12 months, the treatment options will be rituximab, splenectomy, and TPO receptor agonist. So always we should assess the patient values and preferences. In patients who are desirable to achieve a long, desirable durable responses, you can go ahead with TPO receptor agonist. And those patients who need to avoid long-term medications, rituximab is the choice of treatment. Similarly, in patients with chronic ITP, so here also assess the patient values and preferences. In patient which in place they have high value of achieving durable response, so we have to go ahead with TPO receptor agonist or splenectomy. If they want to avoid long-term medications, then rituximab and splenectomy is the choice. And if they want to avoid surgery, then TPO receptor agonist and rituximab is the choice of treatment. So this is paper is a JIPMER where the studies done with the JIPMER where that's the long-term response in chronic splenectomy patients in ITP. So this is a 33-year study where they have assessed the response of splenectomy beyond 15 years. Initially, even though the response to splenectomy is 40 to 60%, in the long run the response is only 20%. But so post splenectomy they further require lower dose of steroids. So this to highlight that before going for splenectomy, all the other treatment should be tried. So to summarize, the recommendation 1A says that in newly diagnosed platelet count with less than 30,000, corticosteroid is the preferred treatment, and in patients with more than 30,000 count, it should be always observation. In newly diagnosed platelet count with less than 20,000, regarding the admission, if it is a new patient, always do an inpatient admission. Whereas if it is an established patient, the OP basis treatment will be sufficient. In newly diagnosed platelet count more than 20,000, asymptomatic or minor bleeding, outpatient management is sufficient. So regarding the course steroid course, the short course of steroid should be always preferred. And regarding the prednisone and dexamethasone, both have a similar response rates, and it depends upon the physician's choice. In the newly diagnosed patients, the corticosteroids is preferred rather than combining with rituximab. In persistent ITP more than 3 months, based on the physician patient preferences, the TPO receptor agonist, both eltrombopag and romiplostim can be chosen. If it is more than 3 months and non-responsive to corticosteroid, rituximab rather than splenectomy will be preferred. And in between the TPO receptor agonist and rituximab, TPO receptor agonist is the choice. So what other guidelines say? So there is another guideline like joint working group, which is a European Society guideline where have similar recommendations in initial therapy. Initially they start with steroids, but the only difference is this in the second line management, where the TPO receptor agonist is the first choice when it comes to the second line treatment, with rituximab being considered as a third line agent. And regarding splenectomy, they are not directly compared with either treatment. Only it is reserved for patients who have ITP for more than 1 year and who have major bleeding with WHO grade 3 and 4. This is one another Australian guidelines on ITP, which is established in 2024. Here, the primary and second line therapy is similar to ASH guidelines, but beyond second line therapy, coming to the, beyond second line therapy, if there is a persistent low platelet count, they assess the need for hemostatic response. If it is less than 4 weeks, and the preference will be like this. That is, if we have to avoid infection or thrombosis, Dapsone is the choice. And if there's an acceptable higher risk of infection, MMF will be the choice. And if there is no immediate responses needed, and if the ANA positive or SLE confirmed SLE is the HCQ will be the choice. And in patients with acceptable higher risk of infection and females of childbearing age, azathioprine and CSA is the choice of treatment. And in males, danazole is preferred third-line option. So this slide is to highlight the various treatment option and their time to response and overall response rate. First, in initial treatment, the prednisolone, high dose dexamethasone, and IVIG. The overall response rates are similar, like 60 to 80%. The prednisone have time to response in 1 to 2 weeks. High dose dexamethasone 1 to 9 days. IVIG in 1 to 4 days. In the subsequent treatment, eltrombopag and romiplostim, they have 60 to 80% response rate, and rituximab has the time to response is 1 to 8 weeks, and we have a response rate of 60 to 80%, and the response durability is 40 to 50%. The other subsequent treatment with less robust evidence are azathioprine, cyclosporine, cyclophosphamide, danazole, dapsone, MMF, and vinca alkaloids, which altogether in which the maximum all have the overall response rate of 30 to 60%. So few words on new drugs in ITP. So this is a picture showing the recent drugs like lisaprotinib, which is the proton tyrosine kinase inhibitor, and fostamatinib, which is the SYK inhibitor, which blocks the downstream PCR signaling pathway and that way prevents antibody production. And other drugs which has been tried in ITP are like sirolimus, and then oseltamivir, decitabine, bortezomib, or few other drugs which are studying in ITP. Thank you, sir.
Okay, thank you, Meghla, for taking us through those guidelines. Now, I think we'll get comments from, I think, Dr. Biju and Dr. Joseph on its appropriateness for our Indian scenario and their recommendations.
Yeah, so I first would always say guidelines are guidelines, and most of them are Western guidelines. So they are useful, definitely, but I think there is a lot of times when finances play a more important role in treatment rather than being guidelines. So if it was, say, a patient who says money is not a problem, then I think it's easy to follow the guidelines. So you have IVIG, you could use rituximab upfront or corticosteroids. Then you have rituximab as second line if you want with TPO agonists. And then you decide whether you want to go down the line. But for all practical purposes, for a lot of patients, we would use steroids upfront. After that, if they fail, then for us, the second go-to is still azathioprine and dapsone for a large number of patients, because the cost, it is much more cheaper. We know, at least from past experience, 50 to 60% would respond. We have at least 30 to 40% long-term remissions. And interestingly, actually, from the guidelines that were presented, so if you look at TPO agonists, 60 to 80% will respond. It drops down to 40 to 60% when you're on maintenance. And if you look at what they've written, when you discontinue drug, only 10 to 30% maintain their platelet counts.
Correct,
So
correct.
down
Yeah.
the line, all of them drop. So to me, in India, splenectomy is still a good option. We published earlier chronic ITP, adults and children, 5 and 10-year survival rates of more than 90%, and even free survival of more than 70%. So that is a one-step treatment which may still be cheaper than taking eltrombopag or romiplostim for 6 months to 1 year.
Right. Just to bring in one question from the chat box, Biju, I think one part got answered about splenectomy, which you mentioned. So the question from Hamza on how do you taper romiplostin, unlike eltrombopag? Any plan used there, Biju?
So generally we would start with 2 to 3. I would start usually with 2 to 3 milligram per kg, depending upon. So you start with the 250 vial because you have 250 and 500. So you start with 250. Yes, 125 is also available, and then go up to the level which provides you a platelet count more than 100,000. Then I would keep on the same thing for at least 3 months. And once in 3 months, if it is stable, then I start stepping down. So if the patient was on 250 weekly for 3 months and the platelet count remains above 80 to 100,000, then the options are to come down to 125 weekly or make it 250 every 2 weeks. So that is the way I would keep coming down and then trying over 6 months to stop it.
Right, right. Joseph, your thoughts?
Yeah. So one, I will start from the back to answer that. So basically, one, what Dr. I agree with Dr. Biju in terms of I increase the interval between two doses of romiplastim and then come off. And I'm not too enthusiastic about 80 to 100 unless the patient is looking like that as a bank account. 30,000 above with no bleeding is a reasonable target. And I kind of titrate it and give them a broad overview on increasing the interval between the two doses. So that is for roaming. Yeah. For Eltrumopag, I'm not been using that very frequently, but if at all I use, I will make it. If it is maintained, like he said, long term for 3 months, if it is stable, then we will stop it out. As he said, I would also use dapsone and azathioprine. I think you had your thesis and published that as well on dapsone, azathioprine with about 40%. That still holds good for many of our patients, but we must also understand to getting evidence for these cheap drugs is not going to be easy. The evidence will be available level 1, 2, 3 will be there for the Eltrombopag and Romi available. I would differ in the guidelines on the definitions. I think the definitions are not an all encompassing here. We label it as chronic, persistent, and newly diagnosed for want of anything better. But unless that is going to give you a handle on how you are going to treat, it is not going to be of any use. Even the refractory steroid ITP is a very loosely languaged thing on 5 mg, more than 5 mg to maintain a platelet count of more than 30,000 with no durations mentioned there. So I am hoping that some Indian authors already discussing about it on redefining this for a more operational definitions. That is, or somebody else will come up with that. So in our mind, steroids more than 2 weeks not improving, we would change. Or maybe some of them even 1 week if there is no response, for at least 2 weeks and then taper down. In terms of second line agents, as like Biju said, steroid, splenectomy has a good role. Earlier guidelines, splenectomy came way above Romi and Eltrombopag. However, the industry also plays a role in keeping this evidence up. So that's inevitable. That happens in all the diseases because that is where the studies are not there otherwise. So I would leave at that as my comment. Yeah.
Yeah, so just one thought process on the role of MMF. People are now going on to MMF. We're seeing that toss up between MMF and Azuran if it wasn't the cost factor. Joseph and Biju both.
If ANA is positive, if ANA positive and as a MMF comes up front and without, of course, without any secondary signs of SLE, but if ANA, so that is where the ANA plays a role in deciding the second line.
I agree. I think if there's underlying collagen, MMF is probably better than that as compared to azathioprine.
Fair enough. One question on the chat box again to both. So thrombocytopenia with the cortical vein thrombosis, possibly on a background of ANA or APLA. So how do you manage that?
So this is the holy grail, and this is the holy grail for we need to traverse the DVT was bleeding risk. So obviously, there's no one answer to that. So for the person who asked the question, weigh the risk of recurrence of thrombosis versus recurrence of bleeding. Generally, we say any anticoagulation, the risk of bleeding is 2 to 3%. If the risk of bleeding and thrombosis is more than that, which is 10% in the first 1 month, we would trade off the platelet count to even to 30,000 and give anticoagulation. But less than 20, we avoid. 20 to 30, if it is fresh thrombus, I have to give platelets and give anticoagulation. Of course, here it is a situation I want to anticoagulate. I want it more than 50, but if I can't, I am trading off at 30 as well.
Biju?
Yeah, I agree. I think you sort of have to sort of trade the site of thrombosis. So if it is DVT versus if it's a central venous versus if it's a line-related thrombosis. I mean, one of the things where we more commonly see it is probably somebody who's an ALL on treatment with L-asparagine-induced thrombosis and is in its first week of induction therapy and the platelets are sitting at 10. How do you manage that? So that I think it's a question of balancing the risk of bleed versus the risk of complications that occur with thrombosis. Definitely, as Joseph said, less here we would say less than 30, we would not contemplate giving anticoagulation, or if we had to, we have to give large doses of platelets and then do it. But otherwise, we would just hold on.
Right. So another question on Romi. Romi causes a high hematocrit. At what level should we consider tapering if it's kicking up the hematocrit? Is there any kind of...
I haven't seen, I mean, I would go by the routine guidelines, which is 18, 19.
Yeah.
Then you may need to decide whether you want to come, because it's usually above 18, 19 that the risk of thrombosis starts occurring. So there you may want, because romiplastim itself, there are reports of thrombosis that can occur. Plus, if you have a high hematocrit, then you are at increasing the risk of thrombosis. Then you may decide whether you want to step off the dose a little bit or to try and reduce that.
Right. So Joseph, for you, one question here again. Is there a lowest platelet count which you need for a bone marrow aspiration biopsy? Somebody asked, is
Less
there a
than
lowest?
zero. Less
Okay.
than zero.
Yeah. So Joseph has defined your platelet count which you need for bone marrow test. Okay.
That is a very important
Yeah. So
question
there's
because
no
many people have this question. It's good that you asked. There is no cutoff. You must go ahead and do, but give good pressure support for the primary and the secondary coagulation to kick in, which is more than 5 minutes to 6 minutes. You have to give good pressure if you're doing it on a low platelet. But no need to give platelet transfusion before you do a bone marrow.
Yeah, good. So I think we've covered most of it, except that I think we had to bring one COVID in for sure. So both of you all, are you all seeing a little more thrombocytopenia post-COVID disease / vaccine, and your thoughts on that before we close? I think we're just bang on time then.
I mean, if you ask me, do we see more? I don't think so. To the question, I think one of the questions that was raised is, do you routinely test for COVID if you get ITP?
Right,
I mean,
yeah.
it is not a viral infection which is sort of endemic right now in the population. And so unless there were symptoms, so for us, if somebody came in with a viral respiratory illness and thrombocytopenia as a part of the respiratory virus panel, we would definitely check for COVID. But otherwise, somebody who came asymptomatic with just a low platelet count, we would not be checking for COVID.
Yeah.
I agree. That's fair enough. So, when
your final
people...
thoughts, and then I think we should...
No. So we must also be cautious about people saying, okay, somebody has low platelet. Did you get vaccine? Yes, the entire world got vaccine. So this entire question of I got thrombosis, I got thrombocytopenia because I got COVID, you can ask 100 people and all of them will say that they got vaccine. But the question we need to ask is, all the other patients who got vaccination, how many of them got thrombocytopenia and low platelets? I mean, and thrombosis. So this is a bias in statistics which happen, which people should be aware of. This is availability bias.
Okay, fair enough. Fair enough. I think, the time frame also would come into play, if at all. But I think we need data for that, to be fair, and I think aptly put by Joseph there. Okay, I think we are done from our end. We did present cases and the guidelines, and I'd like to thank the PGs and Dr. Akshita and Dr. Shilpa for your participation. Thank you, and I'll hand it back to Dr. Biju and Dr. Joseph. Thank you.
Thank you, Sharad. There was a lovely discussion that we had. I hope it is either clarified or made things more confusing. Either way, it gives food for thought in terms of how we actually manage. Uh, I'd like to thank everybody from the Narayana Health team who took part in this case discussion and in terms of discussion. And I would now just ask Joseph to say a few words before we hand it back to Intas.
Now that Dr. Biju said there is enough food for thought, and my thought is about food now, and I will hand over to Arun for conclusion.
Thank you. Thank you very much, sir. And today we are incredibly grateful to all of you for joining us in the Blood the Savior. And we have successfully completed a third session of this insightful web series. On behalf of Intas Pharmaceutical, I, Arun Chadha, Vice President of Intas Pharmaceutical, extend heartfelt gratitude to all our esteemed delegates for joining us. As we concluded today the enlightening session of the Blood the Life Savior, I extend my heartfelt gratitude to our esteemed course director, Dr. Bijor sir, Dr. Joseph John sir, for their invaluable guidance. A special thanks to the Narayana Healthcare team, Bangalore, for delivering the today's session under the guidance of Dr. Sharad Damodar sir. And we sincerely appreciate the insightful discussion by Dr. Shilpa, Dr. Akshita, and detailed guidelines presentation by Dr. Mangla. And further to this, engaging the case presentation by Dr. Anusha. So all of their contribution had made this episode truly enriched. So this was the third of our web series, and we'd like to forward to continue this journey as we have already communicated in the beginning that it's a 24 months journey is there. So next session, which will be there, that will be on April 16th, where we will meet again and where we will bring you the more valuable discussion and clinical insightful. Thank you for all for your active participation, and we are hopeful to see you again next month. Stay safe and stay informed. Thank you. Thank you very much, sir. Thank you. Thank you very much.
Yeah.
Thank you.
Thank you. Good
Bye.
night.
Thank you.
Thank you. Thank you, sir.
Thank you.
You.